In 30 to 50% of patients, we can make a safe decision with clinical features that are appropriate to send someone home. And what's creative and I'd say really unique about the Mindray assay is that we were never able to be precise on data that actually had decimal points. Can we discern chronic and acute injury from each other? Let's see, let me think about that one for a second. My name is Fred Apple. I am currently a professor of laboratory medicine and pathology at the University of Minnesota. I am also a medical director in the clinical laboratories at Hennepin Healthcare, Hennepin County Medical Center in Minneapolis, Minnesota in the USA. I direct the hospital lab. I predominantly now run a CLIA-certified research laboratory in the Minneapolis Medical Research Institute. And the name of my research lab is called the Cardiac Biomarkers Trials Lab. And for 40 years, I have been studying cardiac biomarkers. Adoption of cardiac troponin assays and then transitioning to high sensitivity cardiac troponin opened up a new door for call it a little paradigm transition, because initially cardiac troponin replaced CKMB and it improved the diagnostic ability in patients. With the transition to a high sensitivity cardiac troponin assay, which analytically means that it's more analytically precise at the low ends of measurable concentrations, it opened up the ability to do testing such that we could do early rule out of patients who come to an emergency department. Now, every patient that comes in that is thought of, I can use the troponin test to make a decision on whether someone can be triaged immediately to the hospital because they're at high risk of a heart attack, or in 30 to 50% of patients, we can make a safe decision with a very low level with clinical features that are appropriate to send someone home. And everyone that comes to the hospital would rather spend the night at home than a bed in the hospital. So if you think what the high sensitivity assay does, it helps patient care because it gives them an assurance that the result is going to be reliable and there's not going to be any room for, let's say, noise around the result. It also gives the clinician the ability to make a decision to say, you know, you have some chest pain, but it's not cardiac, it's another etiology, and I can put it into an algorithm to make a decision on, I can send you home. And the safety portion is based on patients who come in that go home. At 30 days, you do what you call an outcome. And that outcome is usually predicated on, does someone have a major cardiac event, or maybe they die? And the benchmark for outcomes is to have the safety of a less than a 1% risk of a bad adverse event. Several years ago, I started working with Mindray and their research team in cardiac troponin. And we initiated and were successful in getting some funding from Mindray. And we essentially proposed to do a clinicaltrials.gov clinical study. And the name of that study was called Merit-I. And they're all registered on the clinicaltrials.gov website in the US. And what the study was designed to do was to test the hypothesis if we enrolled consecutive patients, everyone that came into our emergency department, we can decide whether or not we establish a low cutoff to see if we can find a safe concentration that could provide a decision to send someone home early. So before you do the clinical study, you have to take the assay itself and validate it. And what the validation part is, you assess it for its analytical robustness. You want to make sure the precision is good. You want to make sure the reproducibility of a result is good. You want to make sure there are no interferences. So you test it against many other compounds. It could be other cardiac biomarkers, It could be other proteins found, and you want to make sure there is no interferences, because the last thing you want is a false positive result. So you do a analytical imprecision, an interference, and cross-reactivity study. And once we validated it and our data looked just like the manufacturer's package insert, we were comfortable that we could move forward. And the next thing that we did to validate it is we established a universal cutoff, which we define as a 99th percentile. And that's considered the upper reference limit, the URL. And that's very important for diagnostics, that you develop an apparently healthy population and you measure all the concentrations so you can define a male and a separate female 99th percentile URL. So when you're doing these studies for diagnostics, that is your line in the sand that says, we're sure there's been myocardial injury or not. And once that is done, then we start on the MERIT clinical trial to start enrolling patients, measuring values, and collecting all the clinical data. We'll call it a single sample cutoff and what they call a 0-2 hour cutoff. And we do those 0 and 2 hour cutoff because it helps support, sometimes at 0 hour, it's not the right timing. So 0-2 hour, it helps meet the international guidelines, which includes the European Society of Cardiology 0-2 hour algorithm. And what we did is we published a paper on this in the last couple of papers, like 3 in the last 2 years, that showed an algorithm, established Mindray as a really innovative tool to be able to excellent precision. Over 50% of patients could be sent home based on the 0 and 2 hour data. And what's creative and I'd say really unique about the Mindray assay is that in all my career working with assays, we were never able to be precise on data that actually had decimal points. So I've chaired committees and been on committees where we've recommended all troponin data gets reported as a whole number, and let's say 2 nanograms per liter. But the limit of detection for the Mindray assay, which is 0.1, which is quite low for an assay, we showed, I think for the first time, that from 0.1, 0.2, 0.3, all the way up to that 2 nanograms per liter, they incrementally had the precision to independently say each one of those 1/10 of a decimal point has clinical risk implications. So we could go from 1% all the way up to 17% of patients would have the ability, even at those very low concentrations, to make clinical decisions, assuming the clinical picture met what we found, to send people home early.